Hello, my name is Dr. Mark Reisman, and I'm very pleased to record for the Scottsdale Interventional Forum virtual program a talk on valve and valve-TAVR, predicting when the coronaries are at risk. We all know the general nature of the aortic root in the native form in terms of its commissures, the sinotubular junction, the annulus. But this anatomy changes dramatically once considering valve-in-valve therapies. The one part of the anatomy that consistently is important when describing valve-in-valve is the sinus of Valsalva, which you could see here by the arrow is well developed, and also the position and placement of the coronary arteries. And that height of the coronary arteries, as well as the position, will play a considerable role in the risks of coronary obstruction during a valve-in-valve TAVR procedure. When looking at the coronary occlusion concerns, a couple of areas are very, very important. Number one is the initial valve that was placed, the size of the sinuses, the size of the sinus tubular junction or the sinotubular junction, as well as the location of the right and left coronary artery. Here you can see in a native image a valve leaflet that is the native leaflet, which is basically very, very high and up to the STJ, sinotubular junction, and it's causing occlusion of the left coronary ostium. Similarly, in this perfusion model that we have developed, you can see an approach for a valve-in-valve. You can see the TAVR valve being positioned. You see the bioprosthetic valve in place, and you see a small remnant of a stent of the native coronary artery. You can see here the dilation of that valve, and then ultimately that was just a partial dilation, but once a full dilation is performed, you will see that that there is an encroachment upon the coronary artery. And I'll just fast forward this a little bit to demonstrate that once a second inflation was done, you can see how the TAVR valve is compressing the bioprosthetic valve against the coronary artery, thus the risk of There are a large number of bioprosthetic valves that are surgically placed. Each one of them has its more or less unique features, but what's important is there are the stentless valves as well as the stented valves, and both of them, as you'll see, basically provide unique challenges when doing valve. As well as the bioprosthetic surgical valves, there's now an assortment of TAVR valves that are available. And multiple studies have been done looking at the variety of valves, which are higher and lower risk for a valve-in-valve coronary obstruction. So let's talk specifically about the coronary obstruction in this situation. Here's a case of a core valve that was positioned. As you can see, there's no flow in the coronary arteries. And then on the right image, you can see aortic root injection demonstrating complete occlusion as well using the balloon expandable Sabian type valve. There's been multiple publications. This was by Danny DeVere in 2012, and there was an additional one in 2014 demonstrating the outcomes of these procedures. They most frequently present with immediate shock, and with that, it was subsequently demonstrated in the European Heart Journal in 2017 by Ribeiro and colleagues that the mortality was close to 50% if there is coronary obstruction. So clearly, although the incidence is not extremely high, the mortality is quite significant. When looking at the different valves and the potential for coronary obstructions, the stented with externally mounted leaflets seem to have the highest incidence, followed by the stentless valves, and then followed by the stented with internally mounted leaflets. You can see thus that there are different types of bioprosthetics which could create a variety of different situations. When looking at the actual risk for coronary obstruction, as we mentioned, there is the sinuses, which create a measurement which is called the valve to coronary distance. But not only is it important to look at these various distances when trying to predict, but also understanding the position that the bioprosthetic valve has in place, as well as the potential issues of having somewhat of a canted heart valve placed into the surgical valve, and thus creating this somewhat canted orientation, which is very well demonstrated in the middle image. You can see that in the right-sided image, there's just a very, very small sinus of Valsalva and a narrow STJ, and then ultimately you can get obviously challenges with occlusion in those particular situations. Here, just shown very nicely on the right and the left, you see a coaxial aligned bioprosthetic valve in a very capacious aortic root. The virtual THV to coronary distance is demonstrated. The coronary heights are demonstrated. The height from the positioning of the the surgical valve to the coronary is well demonstrated as well. And you could see in the image below on a transverse cut of that, what that would look like. On the right side, you could see when there is a tilted bioprosthetic valve, and despite it being in a somewhat capacious aortic root, you still could run into the problem of coronary obstruction due to the distortion of the way in which the TAVR valve will ultimately sit in place. Here's again some more illustrations where you have a deficient sinus. You have what's called a sinus sequestration. That's when there is contact with the sinotubular junction. And then in D, you can see when you could actually have such a low positioning of the coronary artery that you could actually have a skirt obstruction. That type of issue is almost impossible to deal with when doing these transcatheter procedures. CT imaging, as you would anticipate, plays a significant role in predicting and managing the pre-procedural understanding of the risks of coronary obstruction. You could ultimately identify the commissures. You could check STJ as well as sinus distances. You could place a model of the TAVR valve in position to make a best guess as the risk of coronary obstruction. Here you can see a number of different images demonstrating a high-risk situation where the VTC, or valve to coronary, is approximately 1.98 millimeters, or approximately 2 millimeters, which would be very, very tight and most probably cause obstruction. There's a low-risk case where you see very, very capacious sinuses and clearly no risk at all for an issue. And then you can see in the lower image where there's the potential with 2.54 millimeter VTC and creating a high risk for coronary obstruction. The VTC was looked at through a number of different studies as to what the cutoff should be. And I think most of us will agree right now that the cutoff of approximately anything less than 4 millimeters of VTC to left coronary artery osteodistance is predictive with a fairly high sensitivity and specificity of coronary obstruction. You can see here the control group that was used against the obstruction group, and you can see the line of identity is approximately 4 millimeters. Now, in looking at the classification, as we now have started to look at various procedures, we have ways in which to specifically characterize the different aortic routes. We have the type 1, which is the aortic valve leaflets extend below the coronary ostium, very low risk environment. We have type 2, where the aortic valve leaflets extends above the ostium but below the STJ. And there's 2A, which would be wide sinuses, which would be fairly low risk for an occlusion. And then obviously effaced, where the VTC measurement would be very critical. Type 3 is the aortic valve leaflet extends above the STJ. If there's a wide STJ, that's probably not going to be problematic. And then you have the issues of the effaced as well as the narrow STJ. And that's going to be very important when understanding the size of the valve, the distances, and the risk for sequestration or occlusion of flow into the coronary artery. So when you're assessing the risk for coronary artery obstruction, you look whether or not the leaflet extends above the coronary ostium. If the answer is no, you probably could just go ahead and do conventional TAVR. If it's yes and the VTC is less than 4, then you basically have to consider a Basilica procedure, which I'll just discuss in the subsequent slides. If the answer is no, then you have to look at the leaflets, whether they extend above the STJ, and that is yes. Then you have to use that virtual STJ measurement in order to basically define whether a Basilica would be required. The Basilica procedure is a procedure where we lacerate the leaflet. You can see a conventional standing up almost of the bioprosthetic leaflets in the left image. And then on the right image, you could see both with the balloon expandable and self-expandable valve, how one could provide a laceration and thus create access for coronary flow. The first in-man Basilica, I'm proud to say, was performed in Seattle in July of 2017. It was really guided by my partner, Danny DeVere, and you see in the image Dr. Gabriel Aldea as well. And the idea, again, is a laceration of the leaflet that's in front of the coronary artery, thus allowing flow into the coronary artery. Not only have we learned a lot about this laceration, but we also learned about the eccentricity of the coronary ostium. So it's critical that we understand where the coronary lies with respect to where the laceration is being performed, so we maximize the opportunity to get an excellent result. This eccentricity can be well demonstrated with CT, and CT pre-planning for the Basilica is obviously a critical part of the overall procedural plan. Here you can see also the need for a controlled laceration. Obviously, you want to make sure that you get a nice vertical laceration, so you're basically able to impart the opportunity for the coronary to get the maximum amount of flow at the end of the procedure. In order to do that, there's a lot of pre-planning. Again, using CT, we look at the side view to understand the orientation of the annular plane and the coronary ostium, and then ultimately where our catheter would sit. Called the front view as well. Again, trying to center, or if it's off axis, the coronary artery, optimize the opportunity both in terms of the angulation of the image intensifier as well as where we position our catheters. So in conclusion, coronary obstruction in valve-in-valve procedures is something that still is very significant and important to think about. The anatomical factors are a narrow STJ or a low sinus height, basically narrow sinuses of Valsalva, previously root repair, and low-lying coronary ostium. From the bioprosthetic valves, we know there are factors of the annular, whether it's an annular or supraannular positioning, high leaflet profile, internal stent frame, no stent frame, as well as bulky leaflet. So all of these have to be considered when planning for a TAVR valve-in-valve and avoiding coronary artery obstruction. Thank you very much.